All right, Miigwech merci beaucoup, and thank you for joining us today for our lunchtime health sciences webinar on benefits of weekend physiotherapy on elderly patients' physical function. Today's presentation is delivered by Dr. Venkadesan Rajendran, Advanced Practice Physiotherapist on the Acute Stroke and Internal Medicine Unit at Health Sciences North in Sudbury. I'm Jenda Baker, and I'm the Programs and Partnership Coordinator here at NOSM University. And before we get started, we will do some quick welcomes and introductions. So just a reminder about your microphone being off for the duration of the webinar. The webinar is being recorded and will be posted to our RS and NODIP websites in the future. If you do have any questions throughout the presentation, please feel free to put them in the chat. We'll also have a dedicated question and answer period at the end of the session where Dr. Rajendran will answer any questions that you may have. All of our previous webinars are now on our RS and NODIP websites, and you can find those under the resource section. In the spirit of truth and reconciliation, NOSM University respectfully acknowledges that our pan-northern campus is on the homelands of the First Nation and Métis peoples. The university buildings we occupy in Greater Sudbury and Thunder Bay are located on the territory of the Anishinaabe Nation, specifically Atikameksheng and Wahnapitaea First Nation and Fort William First Nations. Beyond a land acknowledgement, we understand that reconciliation is a practice. We gratefully acknowledge the elders and knowledge keepers who share their gifts and teaching with us, so that we may better understand and honor their wisdom and that of all of the traditional keepers of this land. NOSM University will continue to practice reconciliation by listening, learning, and fostering a cultural mutual respect and trust. Dr. Rajendran is an advanced practice physiotherapist in the Acute Stroke and Internal Medicine Unit at Health Sciences North. He is a clinical lecturer at NOSM University. He has worked as an academic assistant professor at the Lovely Professional University in India and taught various physiotherapy courses to the undergraduate and postgraduate physiotherapy students for over 5 years. He's been practicing physiotherapy since 2003. He is the president and education coordinator of the Northern District of the Ontario Physiotherapy Association. He is one of the co-investigators for the 4 research grants for NOMA. Recently, his team conducted research on how weekend physiotherapy is helpful in restoring functional mobility in older patients and was published in the Gerontology and Geriatric Medicine Journal. Merci beaucoup, Miigwech, and thank you. Dr. Rajendran, thank you so much for your time today. We truly appreciate you sharing your knowledge with us, and we very much look forward to your presentation. I'll now turn things over to you.
Thank you, Jen. Thank you, Jen, for inviting me to deliver a presentation about how weekend physiotherapy is helpful in improving geriatric patients' physical function. And thank you very much for everyone for your time to attend this presentation. This study is funded by the Northern Ontario Academic Medicine Association. Dr. Dylan Falk is a hospitalist who is the project lead for this project. And I'm one of the co-investigators along with Dr. Deepa Jivanandam. So this study is based on our experience as well as based on the available evidence. So I do work at the acute care where I see lots of elderly patients who are not mobile during the weekends. So then when we are providing therapy or intervention during the week, when we are coming back on Monday following the weekend, the patients tend to be less active or their physical function has been declined. So that was the reason actually we thought of doing studies just to see how, in Northern Ontario, this population can benefit from weekend physiotherapy. Because actually we do have limited funding, otherwise we could have included occupational therapy as well. with the limited funding, at least we should be able to work on their endurance or activities of daily living and mobility that will help them to go home over the weekend. So then we decided to do a study. So this study has been collaborated with the senior management at Health Sciences North. The previous vice president was also involved in this work. Then actually we did have lots of difficulties recruiting a physiotherapist over the weekend. Of course, we do have lots of difficulty to recruit regular physios. So it was so difficult to hire a weekend physiotherapist. So what we did was we did actually hire a physiotherapist who is working at the hospital. So we did pay them over time, and finally we were able to conduct this study after a year of break. So these patients, then actually we were able to complete the study and publish in Gerontology and Geriatric Medicine Journal. So the senior management aware of this study, and they found out that this physiotherapy is very helpful during the weekend. So they nowadays they are considering weekend physio for facilitating discharges. So let's, I'm going to actually talk about the background. So all we know that actually elder patients are less active on weekends than on weekdays. So most of the time when the patient is being admitted to hospital in the ER department, they do have a huge wait times. Here in Sudbury, we do have, last week it was almost 60 hours. Now it's reduced to 38 hours, but it is significant. It's almost more than 2 days they are spending in emergency department. Then they are coming back to the unit. When they're coming back to the unit, the nurse actually unsure about the patient mobility status, then leave them in the hospital bed. So when they are spending actually more time in the hospital bed, it causes more deconditioning. It can affect their level of independence which will affect their activities of daily living. So that is called a hospital-associated disability. So the research evidence is showing that the older patient who walk independently to the emergency department, they tend to spend almost 23 hours a day in bed during their hospitalization. So of course it can cause hospital-associated disability. This hospital-associated disability can prolong their length of stay, and also it can increase as the hospital readmission rate, which also can cause poor prognosis and risk of becoming alternate level of care. So that means, when the patient lose their endurance or activities of daily living during their hospitalization, so even when the patient is medically stable, they won't be able to go home because of the mobility issues. So it increases the risk of ALC patients. So many of the hospitalists or the physician actually who is working with the geriatric population, they are well aware of how the mobility is, impacting the alternate level of care system. So we all know that actually the alternate level of care is a major concern in acute care because, it uses inappropriate use of hospital resources, which it also affects the patient flow. It increases the hospital crowding, and also sometimes, you will see due to the hospital crowding, and they put the patient on the hallway, it's hallway medicine, and they even sometimes they have to cancel surgeries. And it also delays the diagnostic testing, and also it delays, there is a delay in the day procedure as well. So the evidence is showing that one ALC patient is occupying a bed, bed access to 4 acute care patients in ED. So it is maybe it may look easier, but it's a very complex process. So that's the reason actually, we thought of doing this study to find out how this is going to improve their physical function. Our goal is actually to develop some strategies so that when the patient is physically stable, when they are medically stable, there won't be any hindrance for discharging the patient to go home. So physiotherapy plays a major role in restoring the function and facilitate discharges. So there are actually numerous studies done in this area with regards to another population like stroke patient, total knee replacement, and coronary artery bypass grafting. All those areas, they found that the additional physiotherapy has been found to be effective effective in improving patient physical function. So in this acute care, especially in Northern Ontario, we did not actually have any data how this is going to affect their ALC. That's the reason actually our team decided to do a study on this population. So our purpose of the study is to evaluate the effects of additional weekend physiotherapy intervention on mobility impairments and functional outcome or performance of high-risk older patients who are admitted to acute medical unit, and our aim is consequently diverting them from ALC bed. So this is actually funded by NOMA. We don't have actually major research grants, so this was a smaller study, but it's a prospective non-randomized controlled study, which was conducted at the medical unit at HSN. So the study was conducted between September 2020 and August 2021. So we included the study duration up to 12 weeks of a patient being assessed, or until the discharge, whichever comes first. So we received approval, ethics approval from the HSNRA Ethics Board. We set the criteria because we don't want to actually intervene all the people who are not a good fit for reducing the alternate level of care. That's the reason actually we chose the criteria. They have to be elderly, of course, with 65 years of age or older, and they have to live in a home or retirement home with a progressive functional decline in function, or with their baseline function either should be ambulating with or without a walking aid, or independent with a transfer who are wheelchair dependent. The exercise intervention should not be affected by their treatment comorbidity, example, dialysis and all. If the patient is having dialysis over the weekend, then we won't be able to intervene them. So that's the reason actually we excluded the patient who is on dialysis as well. But if it's not affecting their dialysis time, we did include them. But the other major criteria is they should have a definite discharge destination. For example, the patient should have a home to go back, or group home, or either they should live in a retirement home or shelter or supportive housing, whatever it is, but they should have a place to live after being discharged from hospital. So we did not include any patient with the medical instability, or patients from long-term care, or patients who are mechanically lifted baseline, or any patients on weight-bearing restrictions, like non-weight bearing or partial weight bearing, like that. But we included actually the weight bearing as tolerated patients. The patient who lacks motivation or who is not consenting to the study are excluded from the study. So we used actually to measure the functional capacity of performance. We used actually functional mobility scale. It's called D. Martin Mobility Index, which is a very easy tool, can be used by physiotherapists or physiotherapy student, medical student, nurse, and general practitioner. It has been widely used in geriatric population. It's a very user-friendly and very less time-consuming tool. And it has been validated in elderly populations in hospital setting. So it has actually 15 hierarchical mobility items, which we can actually rate and quantify the patient functional outcome. The other one is actually activities of daily living measured by the Barthel index. So we all use in geriatric is this tool for geriatric population. So it has a 10 functional areas like toileting, bathing, eating, dressing, continence, transfers, ambulation, and ascending and descending stairs. So the higher score indicates great independence, and lower score indicates actually dependence. So it has a very good psychometric properties in geriatric populations. So in our study, actually, we included 41 patients. Of those, 19 are in control group and 22 was in experimental group. We used a method, it's called consecutive sampling method, because actually it's a non-randomized study. We obtained informed consent from all our participants. The pre-test was conducted within 24 hours of physician order, and the post-test was conducted within 24 hours prior to the discharge. The control group actually received a regular physiotherapy intervention during the weekdays. The experimental group received additional intervention either assessment or intervention during the weekend, in addition to their regular weekdays therapy. So we collected the data, then we use actually Mon-Whitney U test. It's like a non-parametric test. We use that to analyze the between group differences, because actually the data was so small and the data might be skewed. So we use the software Prism to analyze the patient data. The mean age in this group was 79 years. In the experimental group, 23% are male and 77% are female. So predominantly the female. In the control group, the age group was 81 years, and the males were 58% and females were 42%. So when we did actually Mon-Whitney U test, so both actually the Barthel index and Deep Martin mobility index, it shows that there is actually significant difference between the group. So we know that actually geriatric patients, they spend more time in the bed, so which can cause hospital-associated disability, which also decreases their walking ability and increase the mortality rate, of course, if they spend more time in the bed. So the other concern was actually, we don't have any actually physiotherapy over the weekend. So lack of physiotherapy and staff shortages also can worsen this situation. This is actually based on our experience. For example, when we work in acute care, if you might be all physiotherapists, so when any referral entered on Friday, most of the time we see them on Monday, including the weekends, unless your schedule is easy, or you have more time to see the patients on Friday. So they are being pushed back to Mondays. So this is actually a first study we explored in acute medical conditions. So our study showed that the weekend physiotherapy has had significant improvement on patient physical function and activities of daily living. So this study results were also supported by a systematic review in other geriatric medical conditions. So it is important to consider weekend physiotherapy in acute medical units to improve geriatric patients' physical function, which will eventually divert them from ALC beds. So in our experience, actually, most of the time when the patient is being admitted to hospital, if they are elderly, they don't actually, they give them brief. They don't really worry about, asking their preliminary status or mobilizing them. They do, but I just want to rephrase it. Actually, the nurses are very busy, so they may not actually, doing the things what needs to be done. So the nurse also, most of the time, they're unsure about the functional status. They're a little bit nervous about, how the patients are being mobilized. They do wait for physiotherapists to assess the patient transfer and ambulation ability most of the time. They are a little bit complex. Otherwise, they do a pretty good job on mobilizing the patients. But if there is a physiotherapist working on the weekend, but it will eliminate all those barriers. So weekend physiotherapy could assist with reconditioning and prevent deconditioning. It can assist the nursing staff, of course, to determine the patient's functional level of status. And most of the time, the nurse may be unsure about, what gait aid have to be used for this patient, to prevent fall. It's all about, as a healthcare workers, including the nurses, we are trying to protect the patient from a fall, prevent the patient from fall. So they are taking actually more preventative measures to protect the patient. But if there is a physiotherapist working on the weekend, they can actually, assess the function, and they can, inform the nurses about the functional status. So in that way, the nurse can confidently mobilize the patients. So the weekend physiotherapy can restore the patient's independence and can improve their ADL as well. So in conclusion, actually, the weekend physiotherapy had positive impacts on physical function. But because this is a smaller study, as always, the research recommends conducting a future study with a large sample size with a focus on cost analysis. Because this is a smaller study, we didn't do any cost analysis. We were initially thought of doing analyzing the length of stay because the patients are moving from floor to floor, and with the limited staffing and funding, we couldn't able to track down that as well. But in our experience, during the study periods, some of the patients are not being actually included in our study. However, we hired the patient physios, right? So we did actually pay them when they are having time. We did actually help some unexpected discharges. Sometimes actually patients, almost actually during the study period, we assisted almost 12 discharges on the weekend, which those patients actually never followed our study protocol, because actually those patients, they might actually came over Friday night, but they are in a stage to go home on Saturday. The physician wants to make sure the patient is getting a proper walking aid or stair assessment before they are being discharged. So we did assist lots of physicians with the discharges over the weekend whose mobility was questionable during the weekend. So overall, the physiotherapy during the weekend had positive impacts. If you have any question, please let me know. This is a smaller presentation. Actually, this is a kind of knowledge sharing initiative. Thank you very much, Jen, for the invite.
Thank you so much, Dr. Rajendran. I guess we'll open up for any questions specifically to the presentation. I'm sure Brock has some questions. All right, Brock.
Yeah, thank you very much. We started doing a weekend therapy in our hospital about 5 years ago, but we didn't actually study it. So I'm just wondering what, if you can be more specific on exactly, did you keep stats on how many new referrals, how much time was spent with each person, a bit more detail on what constituted weekend therapy?
So we did actually provide presentation to our senior leadership. So they did actually develop the framework who can be actually mobilized. But now at HSN, actually, they do have a weekend physiotherapy, but not specific to one floor. They circulate throughout the units. So they actually tell them to work on the discharges, then the new assessment, something like that. With regards to actually your question, the treatment time, it's of course actually varies from patient to patient and the therapist discretions. So we didn't actually tell them this much time you need to spend, but we did actually encourage them to work on their ambulation, balance, all those things based on the therapist discretion or assessment.
Okay, thank you. Are you going to be tracking any more specific details on what constitutes the weekend therapy?
Yes, actually, we do have a ALC department, so they do track the number of discharges. I think one few weeks ago. I don't keep track of those numbers because the senior leadership does. So I heard from them that recently the physiotherapists were able to, one day they were able to facilitate 6 discharges like that. But it's again the hospital-wide initiatives. So we have actually 6 floors. So one physiotherapist is rotating between the all floors. So they do keep track of. Otherwise, they do feel like it's helping them with the discharges. That's the reason they are continuing to have a physiotherapist over the weekend.
Thank you. And Sheila?
Thanks, Jen, and thanks, Ben. This has been very helpful to learn about your study. I did hear about it on the CBC as well, so congratulations. I'm interested to know a little bit more about the difficulty you suggested about finding a physiotherapist willing to work on the weekends, and I understand that you managed to do that in the study by increasing the workload for someone, and now it sounds like you have someone working weekends. Is that a position that's rotating through a variety of people, or do you have a specific individual?
So, so I will tell the story, Sheila. So this project was actually, we got funding in 2019. So we worked with the senior leadership team. Then we were actually trying to collaborate with, it's called, because the crowding was so much, right? So I did a continuous conversation with the ALC managers and the vice presidents at the HSN. When at that time, actually, they were trying to, promote. We found where the gaps are, right? So we thought maybe actually we will intervene them at the emergency department itself, so that we can divert them from being admitted to the unit. So then actually we were about to launch in collaboration with the emergency department. We do have a full-time physiotherapist working in emergency department at HSN now. It's a permanent full-time job. We were about to actually have that permanent part-time job because nobody took that job. We have to pay overtime to the volunteers. Currently also it's on volunteering basis. They do pay overtime to the weekend physios. They couldn't able to find anyone because we do have lots of unfilled full-time jobs. So this is a big challenges we are facing here. So we took almost 1 year. There was a pause in 1 year with the ED project. When we have great difficulty finding a full-time physiotherapist, then we were finally able to bring one female candidate from BC, who, although she's from Sudbury, but she worked in BC for quite many years. She was able to come in to help us with this project. It was called a mobility pilot project. The project was very successful. Then they thought, okay, maybe we will hire full-time physio. That's how they ended up hiring a full-time physiotherapist in ED. Because there is an increasing number of aging population, right? So they do have great difficulty maintaining their independent level. So they do need a physiotherapist.
Yes, thank you, Ben. And it sounds to me as though the need is greater than what you're able to provide at the moment. So following up on Brock's question, I mean, the priority of the physiotherapist currently employed on the weekend seems to be not necessarily the mobilization of people who might be spending 23 hours in the bed. And speaking from a personal story, I know that at retirement homes where my mother lives, there is very little programming, I will call it, on the weekend. So it becomes a dead space that can create a problem. So
actually, so we do need a OT as well during the weekend, although we did not include the occupational therapist during the weekend in our study. Because of the funding limitation, we did actually inform the senior management that occupational therapist also plays a major role, because sometimes they spend more time in the bed, right? We need a wheelchair. We want them to be mobilized. It's a collaborative work. So we do have a weekend occupational therapist as well, who is working on the discharges. They do actually the PT and OT now working for the weekend.
Thank you so much. Any other questions?
I can just mention to you, Sheila, the way we did it is we rotate, so it comes up, each therapist works about every 6 weekend, and then you get the Monday and Tuesday off. And then recently we had a therapist in town who was interested in picking up weekends, so that's been very helpful too. So we've got a therapist who works every 2nd weekend, so that then means less weekends work for the regular staff, which increases our outpatient capacity because it was being stolen from outpatients to feed the weekend. But that's what we're doing now is a rotation, and as well incorporating someone from the community who wants to pick up some extra hours.
Great. And Brock, do you do that for OT as well?
No, unfortunately, we don't have the funding for OT, and we did look at whether OT would have as much of an impact as the physio, although in the end we decided the physio was the primary focus, as it's usually more physically based versus the OT intervention. It was more about just getting the people to mobilize for the weekend. That was always the target, because we'd come in and find, someone had been on toileting in bed for 3 days, even though they just came from Thunder Bay Regional where they were walking, but they got here and they put them on toileting in a bed until we see them on Monday or something like that. So that was always the focus, was to get them out of bed and just mobilizing to start with, so that they didn't decondition over the weekend.
Sheila, did you want to add to that? Sorry, Ben.
Sorry. Please go ahead.
Thank you. I just wondered if there is more time, I would ask a question about the research itself. And I'm not sure that I fully understood the differences between the control and the experimental group. And I believe you may have said it was a non-randomized style that you used. Van, is there anything more you could tell me about that?
So it is we use that approach. It's called consecutive sampling method. So when the patient is being admitted, it's not randomized because we don't have a pool of patients to start with. So based on the sequence, so we actually recruiting them. Yeah, so that is one of the limitations in our study. There was no funding available to hire a research assistant or research coordinator, something like that. So the funding was so limited. So we thought of, doing whatever is feasible, utilizing the staff members here. Yeah.
Yes, very good. I congratulate you. We need to do the best we can with what we have. And so then it is interesting. There were differences in the two groups, right? And it seems that somehow the men found their way into the control group. Was that what happened? It wasn't about motivation or anything like that. The differences.
No.
Thank you. And so I guess then my final question, Ben, is there anything that surprised you about this research project or the outcome?
Actually, we read actually so many articles to start with, whether it is going to be feasible, to do the study. But the only challenges we found was, recruitment. We were even frustrated at some point. We have funding, but we were not able to implement our project because of the lack of manpower. Then that was actually a big hurdle we faced. But other than that, we had a fruitful outcome. The management aware that it's really helpful for improving the patient function and their discharges. So it's eventually it's turned to be a very fruitful outcome.
Thank you. Brock?
Yeah, just wondering, and you might have mentioned this, is this going to be published anywhere where it can be accessed?
Yes, Brock. Actually, it was published. I will ask Jen to send you the article as well.
Oh, that'd be great. Thank you.
Thank you.
Yeah, we'll share the article as well as the slides with everyone. They'll also be located on our website. We can share the recording as well to anyone who couldn't make it today. Anybody else have any questions? No questions? Well, thank you so much, Dr. Rajendran, for taking the time to present to us today here, and everyone taking the time to, over your lunch hours, to attend. So thank you. And again, if anyone has any questions, feel free to reach out to me. I'm Jen DeBaker, the Programs and Partnership Coordinator here at NOSM University. So have a wonderful afternoon, and anyone in Thunder Bay, be safe. The weather is terrible, so take care, and thanks again.
Thank you very much for everyone for your time. Thank you.
Thank you.
Bye, Brock. Bye, Sheila.